In this next video in our series of basic laboratory tests, we're going to talk about the basic metabolic panel, or BMP. This test is probably one of the most common laboratory tests you'll order, and so we'll talk about what exactly it consists of, what you're measuring, normal values, shorthand notation, and some tips and tricks for using it. The BMP measures 7 basic things, which include sodium, potassium, chloride, CO2, BUN, creatinine, and glucose. Depending on your hospital, many places also include calcium as part of BMP, but we're going to talk about that with the CMP instead. What you're looking for with this test is basic fluid and electrolyte balance, kidney function, and glucose levels. A few examples of situations in which it might be useful are: number 1, if your patient has nausea and vomiting or diarrhea, then you might want to check a BMP to determine its fluid and electrolyte balance. If your patient has a history of diabetes, then you might want to check a BMP to check the kidney function and the glucose levels. A lot of times we get a BMP because we just want to make sure it's not a common issue that can be easily resolved by balancing the patient's fluid and electrolytes. Now, the shorthand notation for BMP looks like this, in which sodium goes here, potassium goes here, chloride goes here, CO2 goes here, BUN goes here, creatinine goes here, and glucose goes here. The normal values for these are here for your reference, but remember that these do vary depending on your laboratory, so don't yell at me if yours are slightly different. Now, for the interesting part, what are some tips and tricks about this laboratory test that might be helpful for you on the wards? Obviously, if any of these values are low or high, you probably want to think about why that is and whether or not you need to do anything about that. But that's not what I want to talk about. I want you to remember 3 useful things that you can use with this information. The first is that you can calculate an anion gap with this information. So if this is your BMP, for example, you would calculate it using the equation sodium minus chloride minus CO2. Let's use some actual numbers. So you want to take your sodium level, which is 140, minus your chloride level, which is 104, minus your CO2 level, which is 24. And that comes out to be 12, which is your anion gap. Assuming the patient has an acid-base disorder, this can tell you if you have a gap acidosis or a non-gap acidosis, which really helps narrow your differential. Remember that the normal gap is 12 or under, but this limit can vary depending on who you ask. The second thing you can do, if it is clinically relevant, is get the calculated serum osmolality. Remember the equation 2 times sodium plus glucose over 18 plus BUN over 2.8? Well, now you do, and hopefully you're not breaking into cold sweats because of it. So let's take this BMP example here and plug it into this equation to find out what our calculated osmolality is in this example. So 2 times your sodium level, or 140, plus your glucose, which is 100, over 18, plus your BUN, which is 8 over 2.8. And this comes out to be 240 plus about 5 plus about 2.5, which equals 287.5 approximately. You can compare this to the actual, aka measured, serum osmolality, which comes from another lab test you can run with your patient's blood, which let's say is 290. So that's your measured osmolality. The difference between the two is called the osmolarity gap, which is normally below 10. Again, I can't stress this enough. Your calculated serum osmolality comes from plugging in the values from your BMP into this equation, and your actual or measured osmolality comes from a lab test. The difference between these two is the osmolar gap. If the gap is elevated or over 10, then this suggests that there is some type of toxin or substance in the blood that shouldn't be there, such as alcohol, methanol, ethylene glycol, hypertriglyceridemia, or hypergammaglobulinemia, etc. The last little trick I want to mention in this video is the BUN over creatinine ratio. If this value is over 20, then this suggests but doesn't prove that your patient is dry or pre-renal. So get him or her some PO or IV fluids before they develop AKI. In this example here, our BUN over creatinine ratio is 8:1 or 8, which is under 20. I won't go into the entire pathophysiology of why this is, but just remember that because creatinine is essentially not reabsorbed by the kidney, while BUN is. So when a person is pre-renal, the kidneys are absorbing everything, including BUN, but can't reabsorb creatinine. The result of this is that serum BUN increases while creatinine remains essentially unchanged. All of this kind of goes out the window, however, if your patient's creatinine is significantly elevated, as you're likely dealing with something more complex instead of just being pre-renal, and your treatment options will be different if this is the case. And here are take-home points. Number 1, the BMP consists of sodium, potassium, chloride, CO2, aka bicarb, BUN, creatinine, and glucose. Some would also argue that calcium is part of this. The shorthand notation that you often see for BMP values as well as normal values are listed here for your reference. And lastly, the BMP gives you enough information to calculate the anion gap, the osmolar gap, and the BUN creatinine ratios, which can be useful pieces of information in certain clinical situations. Thank you.